I'm Darla Clayton. I am the Community Engagement and Fundraising Specialist for the East Coast for Angioma Alliance. And I'm happy to welcome you all to the Atorvastatin Clinical Trial Update with Dr. Awad and his team, which is hosted by the Florida Community Alliance. So welcome, Joanna, and thanks for being here tonight. Before we get started, I just wanted to mention that at the bottom of your screen, you'll see a little box that says Q&A. And if you click that, when you have questions, you can enter them in there and then we can pose them to Dr. Awad. If you enter them anywhere else, we may not see them. So we just really appreciate it if you try to enter them in through the Q&A section. That makes it a little bit easier for us. All right, I'm gonna pass it over to Joanna.
Hello, so we have with us today an international known leader in neurosurgery. He is the director of neurovascular surgery at the University of Chicago Medicine and is one of the world's leading experts on CCM. He has studied the disease for more than 25 years and has developed genetically engineered animal models of CCM. He is also conducting research to identify mechanisms of CCM lesion formations that are the basis for developing medications to treat this disease. He will be speaking more in detail on the clinical trial. So let me introduce to everyone, Dr. Awad.
Thank you, Joanna. You are always too kind. And thank you, everybody. I hope you all had a very happy Thanksgiving. And some of you may be new to the concept of the trial, and some of you may be joining just because you have questions. So we are going to try to give everybody what they really want from this webinar as much as we can. I am very pleased to have with me two members of my team, Agnieszka Stadnik, who is our trial manager, and Agnieszka will be able to answer any questions related to regulations, enrollment processes, consent, etc. And the other really very important person that you would interact with this trial is Christina Paydad. And Christina is the nurse trialist researcher who works with us. She's probably the nurse that knows the most about CCM anywhere in the world, and we work every day on CCM together. So she would be the one that interacts with you when you have questions about your disease and about the trial. And I will be channeling some questions to them as appropriate. So to start with, I want to tell you a little bit about where we are with the trial, and then remind everybody why we are doing it and why we are using atorvastatin. And there are a few questions that constantly keep coming back, so I will try to address them up front because I know everybody wonders about those questions. I hear them in clinic from patients all the time. So the trial now is about a year and a half into a 5-year plan. So we are doing very, very well. The process of the trial involved 6 months of preparations before we could give the drug. So we have been actually enrolling patients for just about a year now. And the plan is to enroll patients during a period of 3 years and to follow every patient for 2 years. So the people who are enrolled first will finish first before the trial finishes. So you may finish the 2 years and not know yet the answer as we continue to follow everybody. The other issue with the trial that you need to know is that at various points during the trial, we will be looking at the data. A person who is outside our team will be looking at the data and telling us if it is time to stop, either because of a safety reason, because of side effects, or because statin is so much better, we must stop and tell everybody that. So we don't have to wait the full length of the trial to get the answer. So I think this is an important thing for everyone to realize. So we are now about a year into the enrollment. We have enrolled so far exactly a third of the number of patients we are supposed to enroll in the trial as a whole. So we have enrolled about 29 patients now. Are we at 29? Is that correct? 29, maybe next week 30 is what we are looking at. And the total number we are aiming for is 80, although that is the maximum number. There is a possibility that we may stop the trial with less patients if we have fewer dropouts and excellent engagement and maybe an effect. So this is how the trial is conducted. I have no idea what each patient is taking, and the patient has no idea if they are taking the actual drug or a sugar pill that looks exactly and tastes exactly like the drug. So we do not know, and you do not know what you are taking, and the reason for this is that is the only way we put aside our biases and we find the truth as to whether this drug works. So two very, very quick updates. The first one is to assure you that at the first review of our data for safety, there were no concerns whatsoever about the safety. The complaints were at a very low rate, what we call adverse events, meaning things that the patients report, were at a very, very low rate, and they were not any different between the people taking the drug and the sugar pill. So if you think you're lightheaded, that doesn't necessarily mean you're taking the drug. You may be feeling lightheaded, but it looks to us like the rates are very similar between the two groups. So far, we are allowed and urged to continue, and this is a very successful trial so far. What it takes for this trial to succeed is really continued engagement. We cannot, this is not a one-stop shop and then we get tired and we don't want to take the drug after 3 months or we change our mind. If that happens, we're really wasting a lot of resources and wasting opportunity for the whole community for us to learn the answer to this question. Is atorvastatin good for me after a bleed, or should I not take it? So that leads me to the next question that is very often asked, which is, if you think this drug might work, why don't you try it on me? Okay, and I will tell you if it's working. If I don't bleed, then the drug is working. So the problem with this is the following. We have some patients who are not eligible for the trial and who have received the drug for various reasons, either because we agreed to give it because they were not eligible for the trial, or because they were started on it for cholesterol indications. Many people take statin for that reason. And let's say they go ahead and have a bleed 6 months later. We will never know if this really was caused by atorvastatin or would have happened even worse without it. And the opposite is true. Let's say they go a year without a bleed. We can never know if this is due to the atorvastatin or if really they would have had a bleed if they were on it or were not on it. So a one patient answer, will never tell us whether this is the right thing to do. And the hardest thing I have is when a patient decides to turn down the trial and they say, well, I am not really sure I want to be on it. And then they have a bleed in 6 months. And then we all wonder, Did we make the right decision here? Would we have been better off? At least we had 50% chance to be on the better option with or without the drug if we were in the trial, and maybe we all will have the answer to this question. It's something every patient who has a bleed struggles with. Should I have done something different? So the trial takes away this decision from you. So we do the best we can since we don't know the answer, and then the answer will come soon for everybody. So these are the issues I wanted to address. The last question that comes up very, very often that I always bring up over and over again is, why are we using atorvastatin and not other drugs? Why are we not using Tempol? I hear about Tempol. Why are we not using the bioaxone drug or even propranolol? So let me answer that. The reason we are using atorvastatin is because it is a drug that has already achieved a huge amount of safety and is already approved by the FDA and has been used by thousands and continues to be used by thousands of patients. The new drugs like Tempol and the new ROCK inhibitors being developed are drugs that have never been given to a human being before. So nobody really knows what those drugs will do. They may grow ears on us or take our hair away or do things we didn't expect. So we have to go very safe, very slow with those drugs, and they are not ready yet to be tested in cavernous angioma. If they are safe, they will be ready for testing probably in about 2 to 3 years at the earliest, and given the steps they have to go through. And this is why we took this opportunity to do this proof of concept trial with a drug that is cheap, available, and we know that in general it is safe and well tolerated. We just have to find the answer if it works and it's safe in cavernous malformation. And then the issue of propranolol, which everybody hears about, as you know, to date, we do not have any evidence of the biology of propranolol in cavernous angiomas. And there are some reports that it helps patients, but there are many reports that it didn't make any difference in patients. Including a very big study that compared the bleed rates of people who were already on propranolol and not, and it found no difference. So we do not know if this drug is really worth testing or not. There is laboratory work being done, so we are already testing mice with propranolol. So we will have an answer whether it works in mice like atorvastatin did, and whether it deserves to step up to be the next drug we test or not. And also it is being looked at in Italy in a clinical trial, and that trial will not have the definitive answer. It's not designed to find the definitive answer, but that trial will also tell us if there is a hint that it might be working. So between the mice and the Italian study, in the next couple of years, we will know if propranolol deserves a place in this pipeline versus the new drugs. So this is the story of atorvastatin and the other drugs and how the trial works. And I think right now, for the benefit of everybody, we should go to the questions and answers. Don't you think, Joanna?
Yes. So one of the questions was, taking atorvastatin for my high cholesterol. So interested if I have any benefits otherwise.
Yes, so we are keeping track of patients who have had a bleed and who are already on statin for cholesterol indications. And we are following those patients in a study known as the trial readiness study. So that study happens at Chicago, Mayo Clinic, and UCSF, and also at New Mexico and Utah. So if you are close to one of those centers and you had a recent symptomatic hemorrhage, even if you're not eligible for the statin trial because you're already on it, you don't have to come to Chicago. Go to one of those centers and enroll in those trials, because what we will be doing is following you on your statin and hopefully find out if the statin is helping you or not. I cannot tell you today if the statin is helping you or not, except that it's helping you for your heart and for the cholesterol. So you should take it for that reason. But whether it's also helping or harming the cavernoma, until we have the answer, we don't have an answer.
Okay. Can one participate in the trial if they aren't able to use gadolinium and iodine for the MRIs?
Yeah. So here again, if you cannot use gadolinium for the MRI for this particular trial, you are not eligible for it, because the trial's biomarkers include MRI scan. The primary biomarker does not need gadolinium. It's called QSM. It measures the amount of iron. But there is another very important biomarker, which is the gadolinium leak in the lesion, which we are measuring and want to know if the atorvastatin is improving that leak or not. And that is one of the questions the NIH asked us to answer. So for now, people who cannot tolerate gadolinium MRI cannot be in the regular trial, but they can be enrolled in the trial readiness, and we follow them the same way as the other patients.
Great. Would atorvastatin be taken until it shrinks, or will it be lifelong?
The atorvastatin?
Yes.
Yes. So in the trial, we give you the drug for 2 years. So you don't have to pay, and the insurance doesn't have to pay or anything. You receive the drug free as part of the trial. Of course, you don't know if it's atorvastatin or the placebo pill, but you get a pill for every day for 2 years. The question of what do we do after you finish is an individual decision. So for those people who finish the 2 years and had been in the trial and don't know what they were on, they have the option of stopping or of us prescribing atorvastatin for them until the results of the trial. But let me explain to you that if for 2 years you didn't bleed, your lesion has stabilized and you may not need the atorvastatin after that. So it'll be a very individualized decision. Now, of course, if you bled already in the trial, then we would have stopped the drug, because that is an endpoint. Once you bleed in the trial, we stop the drug. So if you had bled in the 2 years, you're no longer on the drug anyway, so there's no question about it. But if you are still on it for 2 years and you did not bleed, we make the decision with you individually whether to give you statin after the 2 years or whether to stop it. The standard answer is to stop it, because you need it for really 2 years after a bleed. If we can stop bleeding for 2 years, your lesion has stabilized.
Okay, and then they want to know, where can they find the criteria for eligibility?
Very good question. Christina, what's the best way to give them the criteria for eligibility?
I think the best way is to contact me directly. And I think you should have a brochure, or at the end we can type in my contact information in the chat box maybe. But that would be the best way, because while there are the main criteria, one of which is you have a symptomatic hemorrhage within the last 12 months, there are some other little things that we need to determine, and it would be best if I could help with that directly.
So I think for everybody who is on the webinar, maybe Joanna or others on the team we can send them a copy of the brochure, a PDF copy of the brochure. We had provided it before, just so people know. Or you can go to the Angioma Alliance website that you are all familiar with, and you can click and get the brochure or get in contact with us. Or you can go to our website at the CCM Center at the University of Chicago, and there you also have the contact numbers for Christina. But the best thing is to really get in touch with Christina and myself, and we'll figure out if you meet the eligibility, and we explain to you why you don't if you don't.
And the next question actually goes into this of what are the basic exclusionary criteria? So
yeah, let me summarize some. Agnieszka, do you want to chip in and summarize what are the main exclusions? Or do you want me to do it, or what do you want to do?
I can start. You can fill in if that's okay.
Fair enough.
So main exclusion, we already decided that if you are not able to get gadolinium, then you're excluded. If you had a symptomatic hemorrhage more than 12 months ago, you're excluded. If you're pregnant or breastfeeding, excluded. If you're already on statin, obviously, you're excluded. If you're unwilling to travel, excluded. Those are the main ones I can think of.
Yeah, I think if your lesion that bled has been operated on or radiated, or if you had radiation to the brain for any other reason, those are exclusions, because radiation will alter the brain measurements that we are after. So we want people who bled within the past year. This is a symptomatic hemorrhage, meaning there are new symptoms and new blood on the MRI. So we will review that. So Christina is very good at this. She will get your MRI, will talk with you about your symptoms, and then I will make the decision whether this was a symptomatic hemorrhage. And if it was within the past 12 months, you are eligible. In terms of this issue of travel, there are 3 trips that are required to Chicago. 1 for baseline and enrollment, 1 at year 1, and 1 at year 2. Anything that happens in between, you can come if you want to come for clinical care, or you can have clinical care by your own doctor in Minnesota or in Atlanta or wherever you are, and we can communicate with you remotely and you send us what happened. The only required visits are at enrollment and at 1 and 2 years. So those are the requirements. And for those trips, folks who are traveling from outside the Chicago area get some help with the travel. It's $500 stipend to help you with the travel. Everything else you have at our center, like the drug, the lab tests, is all done free of charge. And the imaging, if it's done clinically, you only get charged for the clinical part. If you are coming only for the research and you are doing your clinical care at your own institution at home, then you don't get charged anything, not even for a visit. So you come and you just have the research part. But in that situation, I am not your cavernoma doctor, so you have to have your own cavernoma doctor. If you want me to be your cavernoma doctor, I will see you as a consultation in addition to the trial work. Christina, does that answer in general the inclusion, exclusion?
Yes, the other main exclusion is if you've had severe history of severe liver or kidney disease. That's the main one too.
Right, so people who have had hepatitis or who have renal failure, so we'll screen for those things and we'll let you know of that. And you cannot obviously be pregnant at the time of your bleed or at the time of enrollment. If you bled during the past year and had a baby, and that's fine, but you cannot come in the middle of pregnancy and enroll in the trial. If that's the case, we let you actually finish your pregnancy and we can enroll you right after. So we have had cases like that, because remember, there is a window of 1 year from the bleed. So let's say you bled, heaven forbid, in your 7th month of pregnancy, we let you have the baby, and then you can still enroll.
Dr. Awad, someone asked, what are the risks of the dose of the atorvastatin used in the trial?
Yes, so this is the dose that is widely approved by the Food and Drug Administration for what we call secondary stroke prevention. So every patient who has had a stroke in this country gets atorvastatin 80 milligram to prevent a second stroke. It's a standard of care. So thousands of patients receive that dose. The side effects of that dose are like the side effects of any statin. Some people feel muscle cramps, some people feel tired or mentally foggy, and some people very rarely have liver or muscle complications. Those liver and muscle complications are so rare that in regular practice, we don't even test your liver test to give you statin. So if you came to my office and had a stroke, we don't even test your liver. We just give you the drug because these complications are so rare. But in the trial, we do all these tests to be safe. So we added layers of safety to it. Now, the complaints of pain in the muscles or joints, in all the trials, they happen in both the patients on statin and the patients on placebo. So it's a very interesting phenomenon that we cannot always dissect. So with individual patients in the trial, if you have those complaints, we discuss with you whether you want to go to half the dose or whether you want to totally get off the drug. And you may be getting off the sugar pill. So we have had some patients that said, we had one patient at least that said, you know, I don't feel the same. Since starting to take the pill, I don't feel the same. I said, okay, do you want to continue or not? She said, no, I want to stop. So that's fine. And now we stopped and we continue to follow her. Another patient had similar feeling, but said, no, I am in it and I'm going to continue. It's not bothering me that much. And maybe at the end you can tell me if I was taking the atorvastatin or the sugar. So different patients will respond to it differently. And if you know ahead of time that you don't want to tolerate any side effects, then don't take it, you know. But remember here, we are trying to prevent a bleed in your brainstem or in your brain. So this is a big deal. And some people talk about taking very risky medications to stop a bleed in their brain. Here, I think we're testing a very, very benign drug.
All right. The next few questions are not really related to the trial, more with CCM.
That's okay.
So the next one is, I was diagnosed with a cavernous angioma in the left temporal lobe of my brain that was found incidentally and causes me no symptoms. The neurosurgeon suspects I had a bleed in 2016 as I was suffering from extreme fatigue, difficulty to find words, and problems concentrating. Recovered pretty well and with no deficits in 2 months. Would it be possible to continue using my contraceptive pill as normal, or should I stop it as it may cause me bleeding? She was on it, or he was on it. She was on it for 5 years, even when I had the bleed in 2016. Obviously, it's a
yeah,
she.
I'm glad it's a she and taking the birth control pill, or we will have a problem. So, there are two questions in that question, and I think the first one has to do with I bled, you know, 3 or 4 years ago, maybe. Right? Maybe, because we don't know if there was the cavernoma and then a new bleed, or you just discovered the cavernoma when you had those symptoms. But anyway, let's even assume you had a bleed 3 years ago and it has not caused any other problems since then. The current evidence-based guidelines say you should just watch this lesion and not do anything for it, not take it out, not take statin, not do anything. But in the temporal lobe, you have to watch for seizures. So what we really tell you is watch for any spells of word-finding difficulties, blank staring, or loss of awareness, even if they are very brief or momentary. those could indicate that this lesion is not silent and therefore may need the medication for seizures or may need to be taken out to stop those spells. But if you don't have any symptoms at all, and including none of those spells, even if you bled 3 or 4 years ago, if the lesion is stable in the past year or more, then it should just be watched. That's what the guidelines say. The second half of this question has to do with birth control pills. So we have suspected for a long time that some women, when they start on birth control pills, bleed from their cavernoma, and there is no other factor to explain it. That's the only thing they did different, and then there is a bleed. We have seen very similar things in many different practices in Brazil, in the US, etc. But as you know, there are many people on birth control pill where nothing happened to them, like you. And therefore, it has always been controversial. Is this just by chance that we had the bleed? So recently, the Mayo Clinic group looked very carefully at their data in women over many years. And they actually showed that the frequency of bleeds is more common when people are on birth control pills that have estrogen. So the best evidence we have so far is that it probably increases the risk of bleeding. But it's a statistical thing, and you have to decide, is that risk worth taking? For most women that I meet in our practice, they can go to an IUD and have a very good birth control system with not affecting their life. And then they eliminate the systemic effect of the birth control pill, including other problems like risks of cancer, risks of stroke that women have by taking birth control pills. So it's probably better to be on an IUD anyway.
Here we have another pregnancy question. With the hereditary CCM, what do you recommend for someone looking to have a child?
So there should be no problem with having children and procreating, because many of us in this community are wonderful despite having some familial CCM. Nobody would say, I wish I was not born because I have CCM. So go ahead and have a family. Now, the risk of bleeding during pregnancy is not that much greater. It's about the same as the risk in any other year of your life. So any woman can bleed in any year, and during the year of pregnancy, there can be a bleed. If that happens during pregnancy, now it risks both mom and the baby. So it is a good idea, if a person knows that they have cavernous malformation, to be involved with a specialist at one of the clinical centers or the centers of excellence who can handle you during pregnancy and work with your obstetrician. But we can tell you that we are very happy to see so many mom and babies come through our practice. And the most common scenario is that nothing happens and you have a great pregnancy and a great delivery of your baby, normally through vaginal delivery. The exception is if you had a bleed during pregnancy, or if your lesion changed during pregnancy, we might ask that you deliver by cesarean section instead of going through the pushing of the labor. But if you haven't had a bleed during pregnancy, then we let you proceed with the pregnancy normally.
Okay. So, sorry, this one was answered. I was taking bioidentical hormones and was told to stop as it could be stroke risk. What are your thoughts?
Yes, I agree.
Okay. I think you previously mentioned that Botox injection should be avoided for people with CAS. If so, why is this?
Yeah, so we don't know for sure, but what we have seen are situations that are very compelling, where every time the patient received the Botox injection, a bleed happened right after that. So it forced us to look at what could Botox do. And as it turns out, the molecular signaling in the cavernous angioma can get activated by Botox. So there is a molecular switch in the cavernomas that is sensitive to Botox. Now, whether that really raises the risk in everybody or in somebody who was otherwise going to have a bleed, maybe their lesion is already ripe and now the Botox just adds to it, I cannot tell you, but I think our recommendation is if you don't need Botox for life-saving indication, which I'm not sure what that would be, then don't go for it if you have an active cavernoma in your brain, because there may be a link there. So for migraine indications, there are many other treatments we can use for your migraine. And for facial pain and for other indications, there are almost always other options than Botox.
Great. So one more, doctor. My husband had an MRI in April and another last month. The doctor earlier in the year referred to his as microbleeds, but I am confused about what that means and if he really does have bleeds in the past year. His most recent MRI was at Mayo last month with no new bleeds. Do microbleeds mean he has had a bleed or bleeds, or is that just what a doc who knew less about his condition used for terminology to refer to cavernomas?
Okay, Christina, what do you tell people when they tell you that?
I always ask if they have new symptoms and if they know whether or not there was just new blood on the MRI. If there's not a straight answer, I ask to see the records myself, because oftentimes different doctors are, I guess the terminology can be different. So it's best to, I guess, look ourselves just to make sure.
So every cavernoma has microbleed. So a cavernoma by itself has microbleed. So there is no cavernoma with microbleed and cavernoma without microbleed. So the only question is, do you have more bleeding, and is the bleeding significant? Okay? So this is where the question would be, is there a change on the MRI? Otherwise, the doctor cannot be so smart to tell them you have microbleed. So it either there is a change on the MRI, and that change has to be read by somebody that knows to look at cavernomas, is not just any doctor, and also if there are new symptoms. If the lesion you were told at Mayo Clinic did not change and you have no symptoms, then you have microbleed like any other cavernoma, but that is a benign feature of every lesion. It doesn't differentiate the hot or active lesion. The only thing that differentiates the hot or active lesion is new symptomatic hemorrhage, meaning new blood on the MRI with new symptoms. We call that cash. That's where the money is. Cavernous angioma with symptomatic hemorrhage. So if you have that, you've crossed into another category. If you don't have that, you have microbleeds like the rest of us.
Okay. Any comments regarding Humira for RA?
So this is very interesting. So in animal models, these types of drugs that inhibit the immune system, like they use them for inflammatory bowel disease, for psoriasis, for RA, like Humira, and for multiple sclerosis, those types of drugs have shown a benefit in cavernous malformation in mice. So I am usually not concerned that a person with RA is getting Humira. In fact, it may be helping their cavernous malformation. So if you have a pro-inflammatory disease that they want to treat you with these drugs, it probably will help your cavernous malformation. We have absolutely no evidence that it will harm it. The opposite is also true. There are many people, particularly those that come from New York, Darla, who go to these doctors that want to give them pro-immunity drugs, shots so your immunity is strong. And lo and behold, they have a bleed in their cavernoma after they have one of those shots. Because if you increase the inflammation, the cavernous angioma will act out.
Okay, and any concerns with the new migraine injections?
With what migraine injection? Botox?
Emgality, Amovig?
Yeah, those are okay. You know, we don't have any reason to believe that those are a problem.
Okay. Can cavernous cause insomnia?
You know, it depends on what it's doing to you in general. So if you have had a bleed and you have the symptoms from a prior stroke, essentially, that can cause insomnia in some patients. Anxiety can cause insomnia. And you know, you've just been diagnosed with a cavernous angioma. Some doctor out of the blue tells you you're having microbleeds in your brain and whatever. You probably have insomnia because you're anxious, you know? So I think you have to fight that a little bit with general health advice, and if that insomnia is a problem, you need to talk to your doctor about it so they assess you for a sleep study. We do not want you to have a sleep problem like sleep apnea. If it is a sleep apnea, it could harm the cavernous angioma because every time the oxygen goes down in the blood, that could activate the cavernous angioma. That's what happens in the mice.
Okay, and then I am a woman with a 1 centimeter in my left temporal lobe, almost through menopause, and have had bad sleep deprivation for several years. I finally,
what deprivation, sorry?
Bad sleep deprivation for several years. I finally took very low dose mirtazapine, which helps. They're taking 1.8 milligram of it, and they're asking if that drug is safe.
What drug is that?
Mirtazapine. There you go. Sorry.
What is it, Christina?
I'm looking at. I'm trying to find the brand name of it. But
so that's what we do.
Safe.
We basically look and try to find out if it is a drug that has any hormones or any activation. So what is it roughly that you can tell?
It's also known as Remeron.
Oh, Remeron is okay.
Yeah, that's fine.
So that drug is okay, and there should be no problem with taking it if it's helping you. If you had sleep problems in the past, thank God it obviously did not make it bad for your cavernoma because your cavernoma seems to be doing okay. But again, these left temporal lobe, just watch for any spells where you have speech impairment or blank staring or anything like that, because they could be mini seizures.
Okay. Well, doctor, you have answered everybody's question tonight, so we truly appreciate it. You want to share anything else, or I know we're going to be doing another one of these webinars first quarter of 2020, and we look forward to hearing more about the trial then.
Yeah, so just one concluding thing. I think we have been working with the Angioma Alliance team, particularly with their new research nurse, Kristen, and also Connie, on how can the Angioma Alliance facilitate enrollment in this trial and having people stay in the trial. So we encourage you, if you join the trial, to connect with other people, to encourage other people. And I think the Angioma Alliance is very, very committed to also encourage you. So if you have any concerns, of course, you call us about anything at any time, 24/7, and we'll answer it for you. But if you prefer to have someone else talk with you, that's what the support system with the social media that the wonderful ladies and the guys at the Angioma have. So connect with others and get some support, so you get to us and we answer your questions, and hopefully you can stay, you can get into the trial or stay in it if you are eligible and you wish to do that. Anything else, Agnieszka or Christina, that you want to add to the community?
I think Christina added her contact information to the chat. Mm-hmm. So I'm sure it'll be sent out as well, but everyone can look at that, the email address and the phone number to contact with.
And if any question comes up, you do not have to wait till the next webinar. We are all available to you, and you contact me, you contact Christina, you have all the numbers, and you don't have to be enrolled in the trial. So don't worry about bothering us. Bother us. We'll answer you and we'll tell you if you know, that there is nothing here, or yes, there is, or whatever. So we'll work with you if you have any issue that could relate to your eligibility and you're wondering about it. We want to be able to answer these and allay any of your anxieties. Thank you so much for everyone who joined us. Happy holidays, everybody. And if you have a bleed and you're eligible, we're here for you.
Thank you.
Thank you, Joanna and Dr. Awad. Thanks for
Thank
coming
you,
out,
Agnieszka
guys.
and Christina, and thank you, ladies, for organizing this.
Of course.
Have a good holiday. Bye.
Happy holidays, everyone.
Bye.
Bye.
Bye.